It is 7:30 and we are going to do our bi-monthly ultrasound case series. Just a reminder that then we had a little switch, but the next case is on November 20th, so that's 2 Fridays from today. Julia Iafredi will be given a lateral ankle case, and today Ashwin Rao will be given an anterior knee case. So we had a switch, but we're still sticking with the same schedule as far as timing. So we're fortunate this morning to have Ashwin. Ashwin comes with us via the West Coast, so we were just talking about getting up early. Ashwin actually is a transplant from Ohio. He went out to Seattle for his residency and did a fellowship at the University of Washington, where he's now an associate professor. He's the program director for the fellowship. I was asking Ashwin what percentage of his practice he incorporates ultrasound, and 75%. So again, like some of us, the majority of the practice involves ultrasound. Again, with the skills that he has, obviously he's getting referrals specifically for this. So again, we're fortunate this morning to have Ashwin with us. So take it away, Ashwin.
Awesome. Well, let me see if I can, oh, it says I need to, the host has disabled screen sharing. I'm not sure if that's.
Here, I'll make you a co-host.
Perfect. Let me try that again. And let's try that. And let's try that. Does that look good to everybody? Hopefully okay.
Yep, perfect, Ashwin.
Perfect. Awesome. So yeah, thanks everybody who's here for attending. I know that it's fairly early for everybody across the country, and it's about 5:30 here, and so I'm no longer a resident or a fellow, so this is rather early for me. So in case I bring up my mug occasionally, I apologize, but it's my way of keeping myself going. My charge today is to talk to you about the sonographic evaluation of anterior knee pain. And so I will say that simply looking and focusing on anterior knee pain, while clinically highly relevant from an ultrasound standpoint, was actually a bit of a challenge to say, how can I turn this into a half-an-hour lecture focusing really on the anterior knee without talking as much about anteromedial or anterolateral pain, because there are other talks about some of those, or I should say medial or lateral pain. So bottom line is this talk will incorporate some parts of the medial and lateral exam that are relevant to anterior knee pain. As Doug and Ryan mentioned, 75% of my practice is ultrasound based, and how I incorporate it might be simply doing a quick bedside scan to support a clinical judgment or an evaluation or do some follow-up. But I also do diagnostic procedures and am billable to do that at the University of Washington, having been able to do that, do a wide variety of procedures in our clinic like Doug and Ryan and others on this call. And one of the things I talk about with ultrasound as you go through your own training is that it's a great way to really get good at this and to gain some skill set to be able to differentiate yourself from other providers, not only primary care or other specialty providers in sports medicine, but really other physical therapists, chiropractors, massage therapists, other allied health professionals in the sports medicine setting, because it allows you to have a skill set that other people do not possess. And so many of my referrals, my practice is essentially referral based. And the reason why I'm at 75% of my practice using some level of ultrasound is that I'm often getting a patient who has been seen by multiple providers. And I almost think of myself as a quaternary care provider, because most of my referrals are from sports medicine providers, let alone other physicians. And so I'm going to dive a little bit into sonographic evaluation of anterior knee pain. At this point, most of you have had a fair bit of experience with anterior knee pain, I would hope. It's one of the most common presenting complaints in a sports medicine setting, and quite relevant in terms of just thinking about how to implement in your practice, because it comes in so frequently. And so we'll start with a case, and that case I'll refer back to over the course of this lecture. We'll go through a little bit of background information because I think it's relevant. We're going to talk a lot about key structures, because I want to talk a little bit about how the key structures relate to your evaluation. Then we'll kind of go back into a scanning approach and go through a couple other kind of quick hitter cases, just so you can get some information regarding other cases that might present similarly to the one that I'm providing. And then we'll do a brief snapshot at the end of my ultrasound report. And as others have said, there's some variability as to how you can put together your ultrasound report. The bottom line is you want to be comprehensive and look to your insurers as well as to what they deem to be a complete ultrasound report. If they are judging you or do a chart audit, you don't want to get caught up in having an incomplete report, then suggest that you're not billing accordingly. So those are the objectives. So why would we ultrasound the knee? This is a table from an article by Jacobson and his colleagues in 2016. And if any of you don't know John Jacobson, I hope you do. He's a great guy. I've met him a couple times briefly. He's pretty close with Doug and Mederic and others who've organized our ultrasound series over the years. He is a leader in sports ultrasound as a radiologist in Michigan. And he has a number of great articles that if you just do a quick PubMed search, you're going to find a lot of cool, not only basic, but advanced articles on ultrasound. So just be aware of John's name. In that article, he provided a table that said, hey, when might I use the ultrasound as a sole modality for evaluating a knee via imaging? And so there's a number of different pathologies that you might encounter that really all you need is the ultrasound if your clinical suspicion is high enough based off of the history. And so I think ultrasound, you can see, is quite a valuable technique. You can save people MRIs, plain films in some instances, other types of findings, depending on what the disease presenting itself seems to be, and then applying an ultrasound and seeing if it matches your clinical suspicions. So for example, quadricep and patellar tendon disease, which we'll be talking about, prepatellar bursitis, obviously, joint effusions can be easily evaluated. I'm sure a lot of you have seen those at this point, but collateral ligament injuries, as well as other areas, all very important techniques by which ultrasound can really be applied well. So what about a differential diagnosis for anterior knee pain? I know most of you guys are muted, but normally I'd call out and ask for a differential diagnosis of anterior knee pain. But in this instance, trying to be efficient here in the talk, we'll talk a little bit about different opportunities, and I'll just go through those. So, quadricep tendinosis, or tendinitis for that matter, but particularly tendinosis or chronic changes in the quadricep. And similarly, patellar tendinitis and tendinosis. Plica syndrome, which you guys might have come into contact with, is another important cause of anterior knee pain that might present similarly. Pes anserine bursitis gets us more towards the anteromedial knee, where the sartorius gracilis and the tendinosus attach in that area. And patellofemoral syndrome you can evaluate as well in this manner, evaluating the patellar facets. Osteoarthritis can present with anterior knee pain. A more zebra diagnosis that I've come across is one of those things that if you are not aware of, you may not see, and that might have seen you, as I think Ryan mentioned in his talks. There are diagnoses that might see you that you, if not aware of, will not see. And so this has become more of a diagnosis that I've seen recently, or I should say saphenous neuropathy. I typed it up wrong at 10 last night, but it's saphenous neuropathy that is relevant here, and then loose bodies as well, and other bursopathies. So let's talk a little bit about a case. So you have a 38-year-old male recreational basketball athlete presenting to your clinic with 5 months of right anterior knee pain. Onset was initially gradual, and he describes this lead up of aching knee pain, but after his game, that pain suddenly became sharp. So basically, he was just dealing with it like a lot of 38-year-old recreational male basketball athletes do. But after a period of playing basketball and noticing that the pain suddenly became sharp, he became more concerned enough to get checked out. So he presents to your clinic and he describes this vague peripatellar discomfort, but he kind of points more to infrapatellar. As you guys know, in many of these diagnoses, anterior knee pain can be fairly vague in its localization, but in his case, he sort of moves a little bit inferior to the knee, patella specifically, in pointing to his pain. And he reports that the pain is worse with activities that are ballistic or plyometric. So running and jumping activities in particularly are painful. And he typically doesn't have that much pain, if any pain, at rest. He denies that he has noticed any obvious swelling or instability, so no mechanical symptoms. And he actually did have a prior history in this knee, remote history of meniscal tear at age 26, but he hasn't really had any issues with that knee, he reports, since that time. So something else to factor in terms of his symptoms. So when you do a physical exam, he has no obvious swelling. His range of motion is full and symmetric. He has no obvious extensor lag, sorry, not log. His strength is a little diminished due to pain when you load him in extension from a flexed position. Otherwise, hip flexion with his knee extended, that strength is fine. The remaining testing is essentially within normal limits, including special tests. He is tender along the inferior margin of his patella, particularly along the proximal patellar tendon. So hopefully the diagnosis is starting to clarify a little bit just based on his history. And that's more or less where he's indicating where his pain is. So just keep that area in mind. You get some plain films, which are essentially unremarkable. Often the case in somebody who's in their 30s is they're gonna have negative knee x-rays if they've been taking care of themselves and they don't have any predisposition to arthritis or any history of trauma. Now, he had a meniscal tear, so you might imagine that there may be some findings if you got x-rays, but in his case, he doesn't have any real findings on x-rays. These are negative. So once again, just reminding us of our differential diagnosis of anterior knee pain here and what we were thinking about, with the caveat being I mistyped sural neuropathy. This should be saphenous neuropathy, so the saphenous nerve. So let's talk a little bit about anterior knee anatomy and what's important in terms of factoring in an ultrasound of the anterior knee. I think the first thing to keep in mind is positioning. You want to be well positioned yourself as a provider. One of the things that I really like to do, and this is up to many, there's a fair bit of difference between providers who do this, but I'd like to involve my patients in the ultrasound experience. I think it gives them a lot of buy-in in terms of seeing the structures that you're seeing, having you walk through their evaluation with them, and it gives them a sense of extra care. And I've found that to be very beneficial to the therapeutic bond and relationship. But one thing you want to make sure is that you have the knee of that's being evaluated also in the right position. So having that knee with a towel roll or two underneath the knee will help put it into a 20 to 30 degree flexion, which will then allow you to better evaluate some of the structures we'll be talking about. Now, there's a couple other evaluation methods which we can go into, but generally that's the position which will get you the most bang for your buck as you evaluate. As always with ultrasound, you want to try to see things in orthogonal planes, so in short and long axis. And obviously, you want to factor in your key structures when you're doing an anterior knee evaluation and trying not to miss structures that might be causing that pain. And I tell my learners that really, no matter what you do, be it a physical evaluation or an ultrasound, I have people essentially do as comprehensive an evaluation as they have time for, and ideally, a full comprehensive evaluation, because you may be led down the wrong path. For example, if somebody has what you think is patellofemoral syndrome, but turns out to be saphenous neuropathy, those present very similarly, and you might miss one if you don't scan high enough to evaluate the saphenous nerve. So something to kind of factor in when you're sort of building both a basic and an advanced ultrasound skill set. So as I mentioned, positioning, this is just a picture of what a typical patient's knee might look like without the towel rolls below them, but that position there. And it'll give you an image that looks more or less like this if you're in that long axis, with this particular case being an evaluation of the quadricep tendon in this area. So as I mentioned, orthogonal views. Here's a demonstration of what orthogonal views of the patellar tendon would look like. Hopefully this is a scan that you guys are all quite familiar with. On the left, you see the image of the patella with the patellar tendon approaching it from the right side of the screen towards the left. One thing to keep in mind that the examiner here did it quite well was they positioned the probe in a manner which you lose anisotropy. In many instances, the patellar tendon, because it curves as it approaches the patella, if your probe is sitting flat upon somebody's skin without adjusting, you may come across anisotropy, which may lead you to a diagnosis of pathology when there's no pathology there. Another way to kind of contend with this is just to play around with your probe position to see if you can correct for any potential anisotropy. and determine if what you're seeing is truly pathologic or not. And then again, seeing things in orthogonal planes, you see in the picture to the right, a cross-sectional view of that patellar tendon, which allows you to potentially miss pathology, to avoid missing pathology that might not be in the plane that the long axis view was obtained in. So for example, you can see, I don't know if you can see my pointer, but there's a little lesion here that if you sliced and just did a longitudinal axis view through this plane, you might miss some pathology in this area. So something to factor in. So key structures. I think this is sort of the meat and potatoes of this talk, but the idea is that when I divide up the anterior knee, this is sort of how I go about doing it. I think about structures superior to the patella, and then as I'm scanning inferiorly, I move to the superficial aspect of the patella, so making sure not to miss overlying the patella. And then looking a little bit more anteromedially and anterolaterally, and we'll go through that, but there are far more evaluation methods to dive into if you're focusing more on the medial or lateral knee. We're gonna really keep it to the anteromedial and anterolateral knee. And then we move to inferior to the patella as well. In many instances, if the pain is more vague than truly anterior knee pain, I might do a posterior knee ultrasound as well, depending on what time and what their patient's presenting symptoms look like. But I'm not going to be covering that here, hence the parentheses. So let's talk about the superior patella. This is a GIF image of quadricep tendon here, and I will pause this guy. Oops, didn't let me pause. All right, well, I guess I'm not pausing it. But there's a few findings here that we can go into, but the key findings and key structures you want to look at superior to the patella are your quadricep muscles, the 4 parts of your quadricep, as well as the tendon. You want to do a careful evaluation of the suprapatellar joint recess, which is essentially just proximal to the superior margin of the patella and underneath the quadricep tendon, where you see a number of relevant structures and may help guide relevant procedures. You don't want to miss your bony structures in case there's any concerns or issues there. And then obviously considering your neurovascular structures as appropriate are your key structures. So getting into the quadricep muscle and associated anterior knee musculature, this is a cross-sectional view of the quadricep, which I think is a pretty classic view if you kind of place the probe mid-thigh, and you can see the 4 parts of your quadricep here with your rectus femoris, your vastus medialis and lateralis, and then your vastus intermedialis with the femur below. So evaluating this structure might be relevant if you are worried about somebody who has a traumatic quad injury or a remote injury that is presenting as quadricep pain or thigh pain, basically. This position is pretty standard, but if you shift the probe so that your vastus medialis, which is in this quadrant here on this picture, is now taking up more of the screen, you then come across the sartorius, and eventually you'll start to get into your adductor muscles here. So this is a picture where lateral is here and medial is here, which is a common probe positioning strategy. And you still see your femur in both of these images, but if anybody is aware, here you see these 2 sort of documented substructures here. Normally I'd ask what those structures are, but I'm particularly curious about this. We've alluded to it a few times, but at the intersection of the vastus medialis and the sartorius is your saphenous nerve. And once again, the saphenous nerve is a structure that can present when irritated as anterior or anteromedial knee pain. It has branches that turn into the genicular nerves, which feed the joint and provide symptomatology in some instances. So in many instances, you can even develop a skill set to do procedures such as radiofrequency ablation. One of my former fellows is doing RFA in our practice now and is teaching our fellows to do RFA for genicular nerves to manage people with chronic knee pain, be it arthritis-related knee pain or refractory things like patellofemoral knee pain. So know that the saphenous nerve sends out branches that are relevant to knee pain. And once you get into evaluating nerve anatomy, neuroanatomy, the saphenous nerve is relevant to this particular evaluation as well. So a diagram of a long axis view of the knee is as such. This comes from, I think, the FP notebook, but these are kind of nice ways to kind of diagram what you might be looking at. And in the superior aspect of the knee above the patella, you have the patella here as your big landmark, which you can anchor upon. And obviously the quadricep tendon is going to be the first muscular or myotendinous structure that that you may come across. But below that is your suprapatellar fat pad and your prefemoral fat pad, and we'll kind of go through that in a bit. But those may not be easy to distinguish one from the other in some instances, depending on how the patient is presenting. But if they have any evidence of fluid buildup, say fluids in the suprapatellar bursa, which is contiguous with the joint, you will see fluid in that bursa, which will then separate out those two fat pads. And so this is a diagram of effectively this image here. So here it's sort of flipped, but you see your patella on the far left here, and your quadricep tendon overlying the joint, or overlying the top of the screen in long axis. And then you might be mistaken here and saying, oh gosh, they have a big effusion here. You can see this hypoechoic, anechoic structure that looks well defined. This is a suprapatellar effusion within the bursa. But keep in mind that you actually have two fat pads here between which the fluid that may come from the knee will accumulate. And that's why people develop effusions that are more noticeable in the superior aspect of the knee when they have an effusion developed from arthritis or trauma. And a lot of times I've had fellows take a look at this structure and think this was just synovial proliferation, essentially synovitis from the trauma or from the issue at hand. But this is actually the suprapatellar fat pad right here, also called the quadricep fat pad, depending on which context you are referring to. And then down here, just adjacent to and superior to the femur, is your prefemoral fat pad. So once again, we're seeing our quadricep tendon, our suprapatellar and prefemoral fat pads, as well as our suprapatellar bursa here in this structure, all seeable via long axis and particularly clear in individuals who have an effusion. So if you turn your probe on short axis, one maneuver I do is I move the knee patient's position from a 20 to 30 degree flexion to a greater flexion. So they're almost like their knee is almost fully bent and their foot placed on the table. So they have a strong degree of knee flexion. And that allows you to have an evaluation of not only the quadricep tendon, but also this structure down here, which is marked as C and F here. So this is your femoral trochlea here, and these are your, this is the cartilage stripe along that trochlear groove, which can be relevant to evaluating conditions such as arthritis. And we'll get into that in a little bit later, but this is a nice view when you're in orthogonal axis to look at the cartilage with the knee in more than 20 to 30 degrees flexion, because you may not be able to bring out the trochlear cartilage without that degree of flexion. So we're moving now a little bit more inferiorly, but now we're superficial to the patella. Superficial to the patella is where you will find prepatellar bursa and prepatellar bursitis. Now I'm putting two different images here up from two different scans. The first image is a little bit more subtle, where once again you have your patellar and quadricep tendon, but here in this structure you see the superficial soft tissue structures, and just in this sort of subcutaneous region here you see this little anechoic stripe within this region, which is a little irregular, but that is evidence of a prepatellar bursitis. Now, in instances where it may be more acute or more visualizable, you may come across something that looks a little bit more like this, where there's more distinct borders to that prepatellar bursa, but don't let this fool you. If somebody has this type of presenting symptom or presenting finding and symptoms that match a prepatellar bursitis, this is likely to be something you want to look at. There may be another bursa forming in this area as well. So just know that there are other areas where you want to pay attention to. One of the nice videos, I'm sure you guys are all aware of the AMSSM ultrasound series, but Mederic Hall, who I'm not sure if Mederic's on this call or not, but certainly one of the leaders in academic sports ultrasound and sports medicine in general, he and John Finoff assembled a course on ultrasound that if you haven't taken a look at, you really should. And the anterior knee ultrasound evaluation makes note that when you're evaluating the prepatellar bursa, you want to make sure that your pressure on the probe is rather light, because this is a structure you can easily compress out of view with heavy-handed probe pressure. So just be aware that you want to gel up, put a lot of gel on, and place the probe rather lightly, and you may identify a bursa that you may have not otherwise seen. So just keep that in mind again. Now, if we're moving not just from the superior aspect of the patella, but moving slightly anteromedially and anterolaterally, there are a few relevant structures in the knee that are worth discussing, particularly the medial and lateral patellar retinacula. And here is a demonstration of the medial patellar retinacula. This is a view that would be orthogonal to the typical view you would look at, long axis view of the patellar tendon or the quadricep tendon, where you're placing the probe between the patella here and the, I believe this is the medial femoral condyle here. And you see this slightly striated structure that drapes between the patella and the condyle here, which actually has a number of different layers to which it attaches, including to the sartorius and to the MCL. That is your medial patellar retinaculum, which comes into play in individuals with patellar subluxations and patellar dislocations. So in an individual who, in one knee, you have a clear evaluation of the medial patellar retinacula, but in their symptomatic knee, if they had a story consistent with anterior knee pain with a traumatic history that suggests that they may have had a transient subluxation or dislocation, you're going to want to evaluate this medial patellar retinaculum in long and short axis to see if you can find it, because you may have traumatized it and caused it to tear, which would then lend itself to potential surgical measures in some instances if there's recurrence or concern that there's lack of stability here. This view also allows you to evaluate the medial patellar facet, and if you apply pressure laterally, you can actually tilt your patellar facet up to get a view of the cartilage in this area, and depending on the person's anatomy. You also see the fat pad, the infrapatellar fat pad in this particular, or actually that's that wrong image, but you see this structure in here, which is between the two condyles, and within this structure is where your plica resides. So here's another image, again, of that patellar retinaculum, and this hypoechoic stripe that abuts the femoral condyle here, and is adjacent to the patellar bony border here. This structure with the white arrows here is your plica, your medial plica. And plica syndrome presents often as anterior knee pain and can be a variant of patellofemoral syndrome that I'm sure you are familiar with. So evaluating the patellar retinacula, here's the probe position that I mentioned earlier, where you're essentially placing it in what I would describe as short axis compared to the axis of the lower leg. And it allows you to evaluate both the medial patellar retinacula, which you can see over here, and the lateral patellar retinaculum, which comes over, sorry, this is medial and this is lateral. So it gives you a sense for these stripy, somewhat subtle structures that you want to pay attention to in the setting of trauma to the patella. So be aware of that. Again, as I mentioned, the medial plica here is a zoomed in view of that plica, which can be hard to see and subtle. I do a fair number of plica injections as part of my practice to try to put cortisone in there in people with symptomatic plica, to use the catabolic effect of corticosteroids to try to shrink the plica, which often can get trapped in this area, and kind of localized impingement, which causes sharp anteromedial or anterolateral pain, depending on which plica is affected. There are plica along the medial aspect and the superior medial aspect, as well as the lateral aspects of the knee that you can feel. Almost feels like a spaghetti noodle when you're running your fingers between the patella and the femoral condyles. And these can be evaluated via the ultrasound, and ultrasound guided injections can be directed accordingly if needed. When we move to the anterolateral knee, in addition to looking at the lateral patellar retinaculum, you can certainly do an evaluation of your lateral collateral ligament, which attaches to your fibular head anteriorly, and your IT band, which actually attaches to Gerdy's tubercle, which is situated on the tibia. So don't disregard these structures as part of your anterior knee evaluation if somebody's presenting with anterolateral knee pain or has a confusing diagnosis. You may want to take a closer look here. This image actually shows it's overlapping this diagram here, but this is a little fluid collection along the IT band that is a potential friction bursitis developing from repetitive trauma in somebody who's a runner who might present to your knee, and obviously common to see runners with anterior knee pain. So be aware of that. Gerdy's tubercle is a tubercle off of the anterolateral tibia, which is important to identify as the insertion point of the IT band and can also be a source of anterior knee pain when people have IT band tendinopathy, where the end fibers of the IT band become pathologic due to repetitive stress and less likely through trauma. So anteromedial and anterolateral pain, and here's another picture here of Gerdy's tubercle with the IT band fanning and attaching to that tubercle along the tibia. You have your meniscus and your IT band kind of coming through here, so that just gives you another view there. So now we're going to move to the inferior portion of the patella, where our key structures here are our patellar tendon, which is obvious, and I'm sure all of you at this point have taken multiple looks at. Below that is your infrapatellar or Hoffa's fat pad, and then obviously your tibial tubercle. Another structure inferior to the patella that may be relevant to anterior knee pain is your pes anserinus. We're not going to really get into that because that tends to be discussed in our medial knee ultrasound evaluation talks, but it's something worth discussing and mentioning at this spot here. Again, a diagram of those structures. So don't forget to be aware of any potential superficial bursa overlying the patellar tendon, which may be present from trauma locally. I see this a lot in people who are laborers who are on their knees quite a bit, will develop bursa along their patellar tendon or their prepatellar bursa. You have your patella here as diagrammed on the left and your infrapatellar or Hoffa's fat pad. If the person has a superficial enough femoral condyle, you may be able to see the femoral condyle and a cartilage stripe in this area as well with your probe in this long axis view inferior to the margin of the patella. So that gives you a view there. Here is a diagram of a similar scan here where you have the patella in this area with the patellar tendon draping and having this sort of view where it's curved a little. And once again, being mindful of avoiding anisotropy to misdiagnose something as normal as abnormal. So the patellar tendon here, you may see bursa adjacent to the tibial tuberosity in some instances, or even adjacent to the patella here. So if you see defined or discrete fluid collections, those might be bursitis. And then Hoffa's fat pad, which is often I use as a marker to determine where I might want to do a knee injection if I'm doing one in an unguided manner and want to have a clear sense of where I want to place the needle. I'll move off the patellar tendon laterally and mark a position where I have primarily fat pad and not the condyles or bony structures that might be getting in the way for an injection, especially in individuals with arthritis where you may see osteophytes and other structures that using an ultrasound can help guide you in that manner. So this is a cross-section view of the patellar tendon here, and just a notable, so every other view we've seen so far has been long axis. This is a cross-sectional view. And again, you want to make sure you get your cross-sectional view because you might miss pathology if you obtain a long axis view along the plane that the pathology does not manifest in. So just be aware that cross-sectional views are important. Again, you see Hoffa's fat pad here below the skin and the patellar tendon in this cross-sectional or short axis view. So back to our case. It took us a little while to get to our case, and we'll kind of finish up here in a few minutes, but this is our differential diagnosis. If any of you guys are not sure what the diagnosis is, you take out your ultrasound after all of this discussion and you start to scan this area, and what you come across is a patellar tendon that has this appearance. And so if this is not clear, hopefully it is, you get a cross-sectional view and you see this appearance here. And so what are we seeing here? Well, what we're seeing is a loss of fibrillar architecture as the patellar tendon approaches the patella, and at its origin in that area, you see this sort of disorganized area here where you see some fibers that are irregular. You might see some thickening of the patellar tendon. You can see it seems to bow out here. And keep in mind that this was sort of presenting like an acute on chronic issue where the person had described some discomfort and aching discomfort in the months or even years before this more sharp discomfort. So this could represent a potential organizing acute on chronic tear in this area. So you get your orthogonal view and it turns out that there's just a whole bunch of hypoechoic change here. If you throw your color flow Doppler on, you're going to start to see the potential for neovessels. So whereas these might look like little tears, they're often signature markings of vascular markings here. So just be aware that you're going to want to throw your color flow Doppler and turn it on, and you're likely going to come across a situation where you see hypervascularity or these neovessels present. One other clinical pearl is if you see somebody with chronic knee pain and a lot of enthesopathy, so where the tendon attaches to the bone, you see hypervascular markings. If there's findings that are consistent with rheumatologic disease, you don't want to disregard rheumatologic disease because, as you guys are aware, there are a number of enthesopathies that are associated with diagnoses such as spondyloarthropathies, that you don't want to disregard if the clinical history and setting is right. So while neovessels are common in just simple tendinopathy, and you may see them anywhere along the tendons, in the enthesis, that is the part of the tendon that's attaching upon the bone, be aware that in some instances, that type of neovascularity, that chronic inflammation in that area, can be indicative of another underlying medical diagnosis. So keep your primary care hats on if you are a primary care provider, and if you're not, just be aware of this as a possibility because it may lend itself to a different course of treatment. So this is a case of patellar tendinosis that ultrasound hopefully will make that clear to you, that there is pathology and pain all consistent with his clinical history. He's a jumping athlete, plays basketball, it all sort of fits. Kind of an obvious case, but I wanted to use it as a bridge to talk about all of these other cases as potentials for diagnosis here. So as I mentioned, we're going to jump back into the scanning approach here, which involves obtaining the short axis view of your superior structures, including your quadriceps muscle and tendon, then moving to a long axis view of your quadricep tendon, identifying those suprapatellar recess structures, including the prefemoral and suprapatellar fat pads. Don't disregard the possibility of an effusion in that area. Switch your probe into short axis and bend the knee to near full bend, and you may be able to evaluate the femoral cartilage and trochlea, and then evaluate your prepatellar bursa and the patella itself as you pass over the patella. And then making sure to slide your probes medially and laterally to get a look at the plica and the patellar retinacula. And then moving to the lateral knee, you can look at Gerdy's tubercle and the IT band attachment there, as well as the LCL insertion, which inserts upon the anterior aspect of the fibular head. And then finally moving to the patellar tendon from its origin to the tibial tubercles where it inserts. And while you're doing that, you can evaluate Hoffa's fat pad as well as any deep or superficial patellar bursa in this area. So that is the approach. Some quick hitters before I finish up. Quadricep tendon pathology can look like this. So individuals with quadricep tendon pathology can often present similar to patellar tendon pathology, just superior to the knee. This is a case of calcific tendinopathy or calcific tendinosis, which you can see the arrow there, this hyperechoic stripe that's lining up along the long axis of this quadricep, the rectus femoris part of this tendon. And then you see a little calcific deposit in short axis as well. These are problems that are amenable to treatments such as 10X or even lavage, depending on how dense these structures are. You can see that this particular calcific deposit is not hard enough to cause a true echo shadow that eliminates the border of the bony structures here. So just be aware that that's something that might be amenable to being removed. And we actually did that. Here's a case of a traumatic rupture of the quadricep tendon. So you see that you've lost that fibular architecture. There's a gap in the tendon here. There's often a lot of ground glassing in the region, which suggests bleeding, but can also obscure your clear imagery of this area. So just be aware that traumatic cases can be somewhat limited on ultrasound depending on how you're doing and what you're looking for based on the lack of organization of the tissue being involved. But being aware that the lack of organization of the tissue then lends itself to the diagnosis that you might be considering. Suprapatellar effusion, something you will all see if you've not already seen, as I mentioned earlier in the talk, sit between the two fat pads in the superior patellar recess between the prefemoral and the suprapatellar fat pads. This is an effusion here. You might miss this if it's fairly subtle. This can serve as a landmark for doing an intra-articular injection if somebody has an effusion here and it's clearly able to distinguish the two fat pads from each other. This is contiguous with the joint space, so it's a nice place to put an injection. Turning your probe into short axis and doing a supralateral approach to an injection using ultrasound guidance is a very effective way to do a consistent knee injection. Sometimes effusions can look larger and more obvious. And again, making sure not to mistake this for synovitis. This is your suprapatellar fat pad and your prefemoral fat pads sort of separated by this effusion here. And the other thing to be aware of is, as I mentioned, synovitis, which can look like even isoechoic or hypoechoic changes within a fluid collection that can be part of the inflammatory process. Sometimes you'll see coagulating tissue that looks like this, which can be just clot that's maturing over time. So just be aware of other structures within your effusions. Trochlear cartilage loss can look like this. So here are 3 different scans of 3 different individuals evaluating their trochlear cartilage. This is their trochlear notch. This is lateral and medial. And you can see this nice stripe here, but maybe a slight defect in that stripe. So this is a grade 2 trochlear cartilage lesion. Here you're seeing changes in the cartilage where you see a nice trochlear cartilage in this region to the right of this image, but then you lose the trochlear cartilage in this left aspect. And that's evidence of a grade 3 lesion. And here you're seeing, it's actually cut off by my screen, but you can see this osteophyte forming here and loss of trochlear cartilage through this region, which is a higher grade or grade 4 lesion. Oops, let's get back to this. Enthesopathy, I already mentioned. This is 2 images of youth-related enthesopathies or growth plate-related enthesopathies. Don't mistake these necessarily for traumatic findings in the young person. This is an unclosed or unfused growth plate and inconsistent, irregular appearance of the fibrillar architecture consistent with tendinopathy or enthesopathy. This is Osgood-Schlatter here, and this is Syndig-Larsen-Johansson syndrome, representing enthesopathies at the proximal and distal parts of the patellar tendon. So a report, as I mentioned, is just a report where you're trying to be comprehensive as much as is needed to both make your diagnosis, which is most important, but also to be accordingly reimbursed without missteps there. And so obviously you want to indicate what your exam type is, the date of the study, the patient's name and identifiers, as well as a brief clinical history. And findings, generally, I summarize in this manner. There are many ways to do this, but I talk about the appearance of the extensor mechanism, kind of focusing on all of these structures in orthogonal views. I describe the presence or absence of an effusion and or synovitis. Make brief mention of the appearance of the trochlear cartilage, as well as the patellar retinacula and plica if appropriate. I talk about if there's any evidence of fluid in the bursa or in the suprapatellar recess, and the presence of any neovessels, all in orthogonal views. So that is the ultrasound report, and that is the talk. So hopefully that was helpful to you and gives you a little bit more. And I managed to get through it with a mug of coffee on the West Coast. So thank you for your attention. Hopefully you guys stayed up as well.
Thanks, Ashwin. That was fantastic. I think Doug hopped off, so I can close this.
Absolutely.
Yeah, very comprehensive. I think your images were fantastic, and you alluded to this a couple times. You know, it's important for us to not, you know, if somebody has anterior knee pain, not to hone in just on the few anterior knee structures that we have or that we know of, but really, you know, think about that patient as a whole and you know, perform a comprehensive examination. So I thought that was really well done. So I don't think anybody typed any questions in the chat. If you have any questions, either shoot me an email or I'm sure Ashwin will be happy to answer any questions.
Sure.
About
my email is really simple for anybody who needs to reach out. It's just my first name, ashwin@uw.edu. So feel free to reach out to me if you have any questions. I always enjoy conversing with you guys as residents and fellows to talk about what's going on in your lives and give you any advice I can pass forward.
Perfect. Thank you. And then just for everybody else, as usual, this is recorded. It'll be on the AMSSM YouTube page to be viewed at a later time. And then just another reminder, Julia Iafredi will be giving the lateral ankle talk on November 20th. So thanks again, Ashwin, for switching the time around and helping us out.
Sure thing. Happy to.
All right, everybody have a good Friday.
Take care, everybody. Have a good one.